Hi, everybody. It's Professor Miller. Welcome to the course, and this lecture is going to talk about altered cellular and tissue biology. So some of this is general, basic, foundational concepts that we need to discuss before we move into different systems and disease processes. Some of it might be a review for you, but we're just going to kind of go through it and look at different areas of cellular injury and adaptation. If you do have any questions, obviously feel free to reach out to me. So in general, let's just talk a little bit about cellular injury. Obviously, there's different mechanisms that we're going to kind of briefly discuss here. I'm sure, once again, you probably have heard of, obviously, of hypoxia. So hypoxic injury is very, very common. It's probably one of the most common types of cellular injury that is typically out there. The difference between ischemia and anoxia is basically determined by severity. So ischemia, once again, like an example would be to the heart. If they had angina and they have reduced blood flow to the tissue or the muscle of the heart, obviously we describe that as ischemia. Whereas anoxia is a more severe form where they actually start to have cellular changes with it. So it's a more prolonged state of ischemia or lack of blood flow to that tissue, essentially, or the cells. So obviously when this occurs, you start to get those cellular responses. And kind of going back to ischemia, like if you have angina, obviously, if we get that perfusion going again, it tends to be more reversible, essentially. Whereas if you kind of go into a more severe process, you start to have those cellular responses, like changes with decrease in ATP. So then they start to have like cellular functions that start to tend to fail, essentially. So they may have failure of the sodium-potassium pump and the calcium exchange. They start to get cellular swelling, and we'll kind of talk about these as we talk about different disease states. Reperfusion injury, once again, you probably have heard of this, especially if you've worked in an area of like cardiac care or an ICU. But reperfusion injury is actually when we restore blood flow to that area. We're also worried about injury to that at the cellular level, once again. And a lot of it is due to reactive oxygen species, and it can actually cause further damage. So it's actually a relatively an area that there's been a lot of research on in terms of treatment with patients for reperfusion injury. This is more, problematic, obviously, in the inpatient setting. In terms of cellular adaptation, these are really foundational areas that you really got to understand because we'll talk about this as we move through the class. Basic terms such as atrophy, and you probably already kind of have a good understanding of this, but when we look at atrophy is essentially, a decrease in that cellular size. So it's not necessarily decreasing the amount of cells, it's actually the size of the cell that's actually decreasing. When you look at it from a broad perspective, you can think about it too as an entire organ. So if you have, shrinkage of the cells, then the organ in itself can actually become atrophic, essentially. It's actually very, very common in skeletal muscles. You'll see this a lot with patients that have, for instance, like a herniated disc or a severe impinged nerve coming from the lumbar spine. They may have atrophy in those lower extremity muscles from it. Or even in the upper arm, if they have neck injuries, you may see atrophy in the muscles essentially there. Atrophy can occur in other organs, such as the heart. Secondary sex organs is another area that's common, and this is more of like a physiologic atrophy. For instance, an example would be your ovaries. Your ovaries after menopause, due to that lack of hormone stimulation, they start to get smaller, essentially. So that's normal. And atrophy of the brain, you may see this with like a vascular dementia, or Alzheimer's is another one that you'll see atrophy of the brain with. So we can describe it as a physiologic process or a pathologic process. So physiologic, obviously, is physiologic, meaning that is a normal response. Once again, ovaries after menopause would be a good example of this. The thymus gland. One other thing I want to mention too is you do have like a separate pediatric patho course that you do cover a lot of this in more detail with pediatrics. And then those that are not doing family, they kind of cover it more in the adult gero course. So we focus mainly on like the general concepts here, essentially. Anyways, getting back on track, where pathologic atrophy would be basically like there's a decrease in the workload there. So if there's lack, once again, going back to the muscle, if there's lack of innervation there, there's going to be a decrease in the work of the muscle there. So then it starts to atrophy. It decrease in blood supply. So if there's reduced flow there, you can get atrophy. Once again, vascular dementia would be a good example of this. Nutritional factors. You think of the older adult. Obviously nutrition's a huge thing in those older patients, and they can get muscle atrophy, and a lot of it's related to protein intake and stuff like that. Hormone stimulation, once again, like I mentioned with the ovaries or even the testes, as you get older, your hormones tend to change. Nervous stimulation, an example again would be like the nerve, like a nerve root impingement where they have lack of innervation to that area where they start to get atrophy there. So those are pathologic causes. This is just an example of a patient, I believe it was Alzheimer's disease or dementia. On the left side is a normal, healthy brain, of a younger patient. On the right side is a patient with dementia or Alzheimer's disease. And as you can see the overall atrophy of the brain. And even like areas like the sulci where they go in, they start to get deeper grooves there. But you can just note that overall general atrophy of the brain. Once again, this is another example too. Like this is a CAT scan of a patient with dementia, severe dementia, essentially. And you can even see how deep those sulci are, where they have the fluid in there, and their ventricles even become slightly enlarged as well, due to the shrinkage, essentially, of the brain tissue, and that's where the fluid accumulates, essentially, with it. So those are just examples of atrophy. Where we also have hypertrophy. So hypertrophy is obviously the exact opposite, where we have an increase in the cell size. And usually it affects the cell size of the organ as well. Very, very common is the heart. And you'll hear this a lot, like left ventricular hypertrophy. You'll see it a lot with long-standing cardiovascular disease or mainly long-standing hypertension. Because once again, it increases that pressure or workload on the heart. And you don't want your heart to enlarge. It's not like a regular muscle, obviously, but that increased workload causes hypertrophy of those muscle cells, essentially. So then they get an enlarged heart with it. It can occur in the kidney as well. So once again, it's at the cellular level. It's not necessarily an increase in fluid, because we're not talking about fluid here. We're actually talking about the actual cell enlarging. So once again, it can be pathologic, obviously, in the cause of the heart or the kidney, or it could be physiologic. And I'll give you some examples of that too. So physiologic would be more of like a hormone-stimulated organ or increased functional demand. So example, like a physiologic would be during pregnancy. So obviously your hormones basically stimulate cellular enlargement, and they actually will get both hypertrophy and hyperplasia, which we'll talk about too. So this is a normal physiologic mechanism. So hypertrophy of the cardiac cells would be pathologic, because that's basically where they're getting increased synthesis of those cardiac muscle proteins, and that basically those muscle fibers are enlarging. So we're getting hypertrophy there. Very common, again, like I said, with long-standing hypertension. Essentially because you're constantly working against, constricted arteries, and it's basically increasing that pressure there to push against that. So what happens is they cannot adapt to increase that metabolic demand. So basically, in order to adapt to this, they start to basically share the work and, enlarge the cells there, essentially. So that workload, or it can keep up with the workload, essentially, with it. This is just an example, a cross-section of the heart on the left side. So obviously the bottom one in the image has hypertrophy there. Once again, you'll see this very commonly on chest x-rays. So incidentally, a lot of times you'll get a report back and it may say, cardiac enlargement noted. And the important thing is to look at your patient's history. Do they have a history of hypertension? Is it uncontrolled? Do they have a history of stents or anything like that with vascular disease? And obviously this will come with time too, but this is just an example of hypertrophy. This is a histology slide of an example of hypertrophy. Once again, you can just see like the cardiac myocytes and how they're enlarged comparison to normal. So next is hyperplasia. So hyperplasia means that there's an increase in the number of cells. So it's an increased rate of cellular division. Hyperplasia is a response to injury. It usually occurs when it's been severe enough or prolonged enough that they have to start reproducing more cells, essentially. different factors can kind of contribute to this, whether it's growth hormones or growth factors, and they basically stimulate these cells basically to divide, essentially. So with hyperplasia, there's actually an increase in the number of cells, where hypertrophy is actually the size of the cell, but they often occur together. So a lot of times you're going to see both of them together, essentially. Once again, hyperplasia can be normal, and there's different types of physiologic hyperplasia. One being compensatory hyperplasia, which is basically an adaptive mechanism that enables certain organs to regenerate. A good example would be your liver. So if a patient had removal of part of their liver, the remaining liver cells compensate for that loss, essentially, and then you have hyperplasia there. It happens a lot in other tissues, like in the epidermis or the intestinal epithelia, your bone marrow, bone, cartilage, smooth muscle cells. So those areas are basically able to reproduce and have hyperplasia, essentially, or increase the amount of cells there, essentially, or regenerate. Hormonal hyperplasia is the other example. This, once again, mainly occurs in like estrogen-dependent organs, such as the uterus or the breast. An example would be in a normal physiologic process. So after ovulation, during a normal cycle, your estrogen, your hormones essentially, or your estrogen stimulates that endometrium to grow and thicken for basically implantation. So it's preparing for the ovum basically to implant. If pregnancy does occur, then you end up getting more hyperplasia essentially and hypertrophy because it supports enlargement of the uterus. So this is an example of like a physiologic hyperplasia. And in this case, it's obviously normal. You can have hyperplasia that's abnormal, and we would obviously call that pathologic at that point. In this case, you can have, abnormal proliferation of normal cells, and it's usually related to like an excessive hormone stimulation or growth factors on those cells. A big one that you'll commonly see, especially like in primary care, or that we worry about, is endometrial hyperplasia. And this is common, or we're looking at for this essentially, or it's a red flag usually after menopause. So those patients that are menopause, and you'll learn this as you move through other courses, but typically menopause, is after a 12-month period of period-free or no menstrual cycles. But a lot of times with endometrial hyperplasia, these patients tend to start bleeding again, and it's because they have an overgrowth of the lining there. So there's a lot of times there's an imbalance with their hormones, like with their estrogen and progesterone levels. The progesterone typically inhibits, endometrial overgrowth. So sometimes there's like it could be an imbalance there that causes it. But once again, if they start to have bleeding in between, after they've been menopausal, it's a red flag because we're worried that they have endometrial hyperplasia, meaning they have an excess growth of the lining of the uterus. And this is an example of it. So on the right side, you can see like your normal endometrium with the uterus essentially. And obviously the cells look nice and pink. There's not inflammation there. There's not excessive swelling or inflammation. Whereas on the left side with the hyperplasia, they start to get an excessive growth of the endometrial lining. And it doesn't necessarily mean that it's cancerous at that point, but we're worried that because of the hyperplasia and the constant growth, that it could be endometrial cancer. So any patient, that we, note this in, obviously they require a consultation with gynecology usually, and they'll do an ultrasound and usually like a biopsy of it as well. Once you get into pharmacology, but another thing too is like when we have women on hormones, if you have a uterus, they need to be on progesterone in combination to basically make sure that they're not getting endometrial hyperplasia. So it's usually the estrogen that is promoting endometrial growth essentially. So it's usually related to the estrogen levels. But that's an example of a pathologic hyperplasia, essentially. And we'll talk about this as we move into women's health, too. Dysplasia, and I'm sure everybody's probably heard of dysplasia at some point in time. One common one that you'll commonly see it is with cervical dysplasia. So basically with this, they have abnormal changes with that cell size, shape, or organization of those cells. So it's really not considered a true adaptive process, but it's really kind of a form of hyperplasia. But really we look at it as like an atypical process. It's not normal. So it's almost like an atypical hyperplasia. So dysplastic cells is what you'll see commonly, like a precursor to cervical cancer, essentially. So a lot of times I said you'll see it in the cervix. The other area that you will commonly see it is the respiratory tract. And a lot of times this is due to, chronic smoking or irritation. But a lot of times too, once again, we worry about this being associated with a neoplasm or neoplastic growth or cancer formation. This is just an example kind of giving you the severity of dysplasia. So obviously at the very top, you can see a normal healthy cell. And you can have degrees of dysplasia. Once again, we'll talk about this in women's health, but, there could be very mild dysplasia and there could be moderate or severe. Obviously, we worry about progression to a actual, invasive cancer or a tumor. And a lot of times with pap smears, when we're doing cervical cancer screening, we'll look for this. And you can usually get, you get your cell sample and the pathologist will actually tell you whether it's, a moderate, severe, or mild dysplasia, and it kind of determines our treatment, our course, our plan, essentially, with the patient. But this is just an example of, how dysplasia could be very mild or can kind of progress into invasive cancer. Carcinoma in stew basically means that it's past severe and it starts affecting the basement membrane of the epithelial layers, essentially. And then obviously it can progress to invasive cancer. Metaplasia basically is replacement of one cell by another. So it's basically adapting by changing the cell over to a different one. This is very common. You'll see this a lot, once again, like with a patient that smokes, because you'll see changes in that, the respiratory tract, the cells of the respiratory tract. Another common time you'll see this is in what we call Barrett's esophagus. You'll see this in patients that have chronic, long-standing reflux or GERD, and they start to get changes in the esophagus. And once again, with these, we're worried about it, becoming dysplastic or, progressing to a neoplasm. So with metaplasia, essentially, it's replacement of one cell, changing it over to a different type of cell. And it's usually in that connective tissue that you'll see this. And once again, I just have an example here that you'll see it commonly, like in the bronchial lining. This is just an example, when you're looking at it on a slide, a histology slide. Normal at the very top, they can have metaplasia, they could have dysplasia or carcinoma in stew. So this is just an example of it. And you can just see the deranged cellular growth and how it changes from normal to a precancerous or cancerous lesion, essentially. This chart just shows you, once again, it's just the ones that we kind of went through with atrophy, hypertrophy, hyperplasia, metaplasia, dysplasia. So in terms of cellular injury and responses, obviously you have the normal cell, and what happens essentially is that, every cell is exposed to stress at some point or time. There's an injury that may occur, and a lot of times it adapts, and it, goes through the cycle, and it turns back to, a healthy cell again. However, there's times where obviously you have irreversible cell injury, and that's where you have cellular death. So we'll talk a little bit about this in terms of cellular injury and different mechanisms there as well. 3 common forms of cellular injury, once again, is hypoxic. That's the most common. So a hypoxic injury causing cellular injury or death, reactive oxygen species or free radical induced injury. This again, like when I was talking about reperfusion injuries, this is an example of it. Or chemical injury. Chemical injuries are another factor, and this could be a multitude of things, whether it's inhaled substance or on the dermis or ingested, whether it's a medicine. So chemical injury obviously can be caused from multiple things, essentially. Hypoxic injury. So obviously it's related to insufficient oxygen to the area. It's the most common cause of cellular injury. And obviously it can cause, or can be caused from multiple different things, whether it's a decrease in the oxygen that they're, consuming or breathing in. Another big thing is loss of hemoglobin or hemoglobin function. So if they are anemic or, they have severe blood loss, obviously it puts them in a state of hypoxemia. Decreased production of red blood cells, once again, that would be like an anemia. Decreases of the diseases of the respiratory and cardiovascular system. And I think all this stuff should make pretty much sense to you. Poisoning of oxidative enzymes, but the most common cause, like I said, is ischemia. So that's typically a hypoxic injury. So in terms of free radicals and reactive oxygen species, A free radical basically is an electrically uncharged atom or a group of atoms that have an unpaired electron. But it has different effects at the cellular level. It can cause destruction of unsaturated fatty acids. It can cause alterations of proteins, which sometimes it causes them to be fragmented or folded, essentially. It can cause alterations in DNA. So basically, that's why you hear a lot about like antioxidants and stuff like that, because it's basically to help combat the effects of free radicals, essentially. And once again, like when we kind of talked about like a reperfusion injury, this is actually a common thing too. But free radicals in reactive oxygen species are they're linked with aging as well. It's a slower process at that point, but it is definitely linked with the aging process as well. Another mechanism for cellular injury is related to chemical injuries, and essentially it's a biochemical interaction between a toxic substance and the cell's plasma membrane, which ultimately becomes damaged. So what happens is it increases permeability. And then two different mechanisms. There could be direct toxicity by combining with a molecular component of the cell membrane or the organelles within the cell. Or number two, it could be reactive free radicals and lipid peroxidation. So these basically can there's multiple different chemical agents, obviously, that can cause cellular injury. A very common one and that we always worry about in children is lead, so lead exposure. And it depends on, a lot of times, like we'll assess whether the child lives in a home that was built before like 1978, because some of the paint and all the stuff that is used to manufacture the home can have lead in it. And I'm sure everybody's heard about lead exposure and all that too. So sometimes depending on where the risk of exposure, will actually screen the patient through blood testing. Obviously, carbon monoxide is another big one that you can come in contact with too, and it can cause direct chemical injury. Ethanol or alcohol, mercury, social or street drugs. There's a lot of side effects potentially from a lot of these different chemicals, essentially, that can cause cellular injury. Some of these are just general areas like unintentional injuries and intentional injuries. And you can pretty much take a look at this, but a lot of this just talks about different injuries like blunt force injuries, abrasions, lacerations, contusions, and then we'll also have like other unintentional injuries like such as gunshot wounds, strangulation. Those are things you can just kind of take a look at. Once again, you can go ahead and take a look at this in your textbook. Asphyxial injuries essentially would be caused from, once again, lack of oxygen. It could be things like suffocation, strangulation, chemical asphyxiants, basically, once again, carbon monoxide, cyanide poisoning, or hydrogen sulfide, and unfortunately, drowning. Essentially, what happens is where they're basically breathing in fluid, so the lungs become filled with fluid, and the gas exchange cannot occur at that point. When you start moving into other classes like health promotion, you'll start talking about, unfortunately, we look a lot at leading causes of death. At different age groups, it's really important to look at what is, the toddler at risk for, what is the adolescent or young adult at risk for, because it really guides the education and preventative care that we provide for our patients. So when you have a chance, I know everybody's busy, but, look at, I hate to say it, but leading causes of death, but it really does give you an idea of where we need to be focusing our education, and preventative measures with our patients or their families, essentially. That's just a side note. Infectious injury, this is another big one that you'll see. And even if you think about it from the perspective of, on a small scale level, like you think about injuries like cellulitis. I mean, you think about how a microorganism can actually destroy at the cellular level and cause a lot of destruction to the tissue there. So obviously, microorganisms can cause cellular injury. The virulence of the microorganism, basically, how disease capable is that organism, essentially. Disease producing potential. Or how likely are they to invade or destruct? So obviously certain bacteria or infections are more notorious for having, greater side effects or long-term effects from it. Some, bacteria will produce toxins, so sometimes there can be a systemic response with this. And we'll talk about that later too as we go into inflammation and infection. But we'll talk a lot about this as we move through that. There can be a production of hypersensitivity reactions because it can kind of trigger this in the patient. And once again, we'll talk about this kind of as we get into different types of infections. Your immune system and the inflammatory injury, basically, once again, there could be, direct contact with cellular or chemical components of your immune or inflammatory response. Once again, we'll talk about this when we move into the immune system and inflammatory response. You'll find that the inflammatory response, you will come across that a lot. When we start to talk about it, I'll explain to you, it really has to do with a ton of different disease processes. So it's actually an important area to really kind of have a good understanding of. But once again, we have all these chemical mediators and all these portions of your immune system, like histamine, antibodies, lymphokines, different enzymes. And essentially, it can cause cellular injury. I mean, it's, the main focus of it is to try to heal, but you can also have, a lot of inflammation and tissue damage in that area as well. It can also have membrane alteration, so there could be leakage of potassium out of the cell, and they could have influx of water in the cell. So obviously you have cellular swelling at that point. But we'll kind of get into this more as we go into the immune system. Genetic factors. There's certain genetic diseases that actually can predispose the patient to this. One example would be like sickle cell anemia or muscular dystrophy. But basically, these genetic factors can lead to alterations, on the plasma membrane, the shape, the receptors on the plasma membranes, or transport mechanisms. So there can be alterations like in their DNA or there's certain types of cells essentially with that too. Nutritional balances is another big one that you'll see in the older adult or even the younger child as well. But obviously, if there's deficient nutrients like proteins, carbohydrates, lipids, vitamins, or minerals, whether there's an excess amount or deficient amount, obviously can cause cellular injury or impairment to the cell function, essentially. So if there's a deficient intake, like they have low lipids or low fat intake, essentially, that's where you start to mobilize that fatty acids from the adipose tissue. So it's almost like going into a state of starvation, and your body actually pulls the fat from your normal store, essentially for normal cellular function. Excessive intake obviously would cause, if they have an example would be hyperglycemia. Obviously excess glucose can cause obesity or diabetes essentially with that too. So obviously nutritional imbalances can cause issues as well. Temperature extremes, hyperthermia, hypothermia. So obviously hypothermia can slow down metabolic processes at the cellular level. It can produce those reactive oxygen species. It kind of goes back from a vasoconstriction basically to a vasodilatation. So there can be, instability of vasomotor control there. But basically they end up with increased membrane permeability. They can have cellular and tissue swelling essentially with that. Hyperthermic injury. You may see this commonly like if you work in the ER or if you work in like an urgent care, but it can progress from anywhere from heat cramps to heat stroke. So essentially they have an imbalance where they lose salt and water, and it kind of progressively gets worse with, heat exhaustion is more severe where they start to get hypovolemia. Heat stroke is very severe where they start to get like circulatory collapse essentially with that. But obviously temperature extremes can cause cellular injury. This you can go ahead and take a look at. Decompression sickness, you'll see that with divers. And essentially they call it the bends. You probably wouldn't see this much unless you work in an area that like an ER, or you would probably see it possibly like in urgent care. But you can go ahead and take a look at this. Ionizing radiation, I'm sure you probably are well aware of this, but obviously any form of radiation, whether it's a test that we're, ordering, we worry about the negative effects of it. So we have to be very cautious with the test that we order, who we're ordering it on, because, with little ones, like you want to make sure we're limiting that. Or another big one is if you have a pregnant patient, you have to make sure they're not pregnant, because it can be obviously cause damage to, genes, it can damage DNA, it can have a lot of negative effects essentially. And a lot of it's related to long-term effects too, and the risk for cancer as well. So the big thing is being cautious about the tests that we order for our patients too. Obviously, there's other sources of radiation, but the medical source of radiation is a big cause, unfortunately. So a lot of times now too, like we'll go to things like ultrasound where they're not being exposed to radiation like that too. But there's times where the benefit outweighs the risk, and the big thing is just making sure that we're not over ordering essentially. Okay, I'm going to go ahead and split this into two just separate videos. So then when you're finished with this one, just go to the next one. I'll have it labeled right underneath it, and I will go through the rest of the slides on that one. Thank you.